Hello and welcome to the 27th Degree with Chris and Nancy. So today we're honored to have Dr. Lakshman back with us, and Dr. Lakshman will be discussing transgender therapies. He runs the Transgender Clinic at Primacare, and we're really, really happy to have him with us today. Before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by signing up as a patron. Go to patron.podbean.com/the27th Degree, or you can click on the link in our Facebook page. $5 a month gets you shout-out access to an exclusive behind-the-scenes content that you can find. You can find the 27th Degree across social media, including Facebook, Instagram, and your favorite podcast platform. You can also subscribe to the 27th Degree Consulting channel on YouTube. I'd like to give a big thanks to Ron Gamache for our intro music and the PC Institute for producing our show. So we'll get right into it. So thanks so much for being here today. This is such an interesting topic. I was really looking forward to discussing this. Tell us a little bit, first of all, about yourself. Of course, I know you, but our audience may not. Let's hear a little bit about who you are and how you got into all this.
Yes, so greetings, viewers, and hello to Nancy and Chris. Thanks for having me here to talk about a topic that's very close to my heart. So I'm Dr. Kishore Lakshman, endocrinologist, and I'm a part of the endocrine division at Primacare Medical Center, where I run the Transgender Clinic, which was established in 2016. And we've come a long way. The journey has been pretty amazing since then. So within the endocrine realm, I offer several therapies. Diabetes is a big portion of that. And then I have other specialty clinics, such as the Transgender Clinic, and also have a men's health clinic where we cater to sexual issues that men would face, and then also have a thyroid clinic. So there's a lot of diversity within the clinic itself, which makes it all the more enjoyable.
Yeah, and just to mention to our audience, we had a great podcast in the past on the men's health clinic, and since that time, there's even newer therapy that's available. So
that's true.
If you're interested, then certainly contact Dr. Lakshman, and he'll have certainly he has therapies that can help. But let's talk a little bit about the Transgender Clinic. Why was it important to you to open a transgender clinic? Let me start with that.
Yes. So the men's health clinic, which was sort of the first sexual clinic to start within the endocrine realm, launched in 2010, I believe, which is when I started here at Primacare. So that had been going on for many years. And I think the increased social awareness for transgender health, the increased need for acceptance, probably started early around that time. And I would get inquiries into my clinic starting early on, even 2012, 13, asking if I was treating transgender individuals. At the time, I was not. I did not have a well-established clinic. I did not have the right environment to welcome transgender individuals, or the right amount of training for myself and my staff to be welcoming to these individuals. So it was mostly, sorry, not at this time.
And one thing that I want to bring up too, this clinic was opened in 2016. So while it's, we hear a lot about transgender now, back in 2016, I, for instance, wasn't hearing a lot. This conversation wasn't occurring in my awareness, so I just think it's fantastic that you jumped on this so early and offered this service.
Yes, and I think the inquiries only started to get more frequent as years went by. And there was one day, I very clearly remember this day, when we had about 3 inquiries, and I happened to be in the front desk shredding some documents. And my staff told me about 3 different inquiries that had come on the same day about transgender individuals asking to see if they can come into the clinic for help. And I think that was pivotal for me. And I said, we got to make this happen. I think there's a lot of people out in the community needing help, and there's nobody in the area providing help. And yes, some of the big cities, Boston definitely has a very established transgender clinic, which is probably one of the oldest clinics in the country. But I mean, Boston is a lot for patients, local patients to travel. A lot of those that have big city anxiety around big institutions, fear of discrimination, and that's very relevant for this community. So I said, we got to make this work. So the same evening, I sat down, had a meeting with my team, who are nothing but incredibly supportive, and we said, let's start with these individuals who said, and let's call them and say, no, I mean, we are starting something, we're launching something.
And I think it's great too, location-wise, because then, people are able to stay within their community and their network and where they feel comfortable. They're not traveling and going somewhere that's foreign and another uncomfortable situation.
Correct. It adds layers of anxiety.
Right.
So then I think within a month, we were able to officially launch.
Within a month?
Yeah, within a month of when that happened.
My God.
That day. And the weeks between, 4 short weeks between then and when I saw my first patient was mostly spent personally for me updating some of the treatment guidelines, then talking to some other providers in different parts of the country who offered care for transgender individuals, and then get the necessary training for our staff to be welcoming to these individuals.
Can you talk about that a little bit?
Yes.
Because that sometimes is an area that people might overlook, but yet you had a great sensitivity
Completely.
to that.
Simply starting with signage in the bathrooms, where it could be more welcoming and gender neutral. So that was one of the things we did, where it was gender neutral bathrooms. Anybody could use. And then the other big thing that we wanted to be very aware and sensitive of is to address transgender individuals by their preferred names. A lot of them have preferred names to mark the identity of their new chapter in life, almost like a rebirth.
Right.
And that calling them by that name gives them incredible joy, a sense of empowerment. Sure. And we like to be welcoming to that. So, we set mechanisms in place to make notations in our electronic medical record. Or we would ask them when they called us to make their appointments if, they had a preferred name that they went by. And we wouldn't forget that. That would be front and center in their chart. So when they came, they were waiting in their rooms, we would call them by their name. And they would be just ecstatic that we actually were one of the first medical offices to actually respect that, because a lot of them haven't officially had name changes or gender changes or that reflected in court documents. Many are in the process.
Right.
So many don't have that as part of their insurance cards or their ID cards.
But it's such a sign of respect and acceptance.
Yes.
To use that name. I've had some patients who, and in other conversations I've had with people over the years where, family members have not accepted their new name, and it becomes such a sense of struggle for them,
Exactly.
and they go by, and unfortunately, family is calling them by their, their dead name. And,
Yes.
And they struggle with that so much.
It is. And I think dead naming, which is an accepted term at this point, widely known, has a lot of repercussions, because I think a lot of the times it's done unintentionally for an office that's not transgender. I mean, we call it gender humility. That's one of the first terms I introduced to my staff, gender humility, that which encompasses the topics that we're talking about. But dead naming can be unintentional a lot of times, but sometimes intentional to mock the person's thing, or to show disapproval of their gender identity.
Right.
And calling them by their names, which they no longer go by, can trigger a lot of unpleasant memories, childhood memories, perhaps acts of violence, or just a feeling of being powerless. So which is why just that first point of contact, when you actually refer to them by their preferred name, brings incredible joy, empowerment. So that's one of the things that we had to first put in place, so there was a nice flow and sort of recognition of that.
Yeah, that's a great way to explain it,
Yeah.
so people understand the importance of
Yes.
using a preferred name.
Yes.
And then the pronouns.
Yes,
fall
I was
into
just going to get to
place
that.
with
So those are the two questions we typically ask. What's your preferred name? What's your preferred pronoun? So him, his, or he, her, she, and every individual is so different, and many, and they're in different parts of their journey, which is why it's so important to ask these questions. Right. For many, I might be the first person, or we might be the first office that they're even talking about this. So they may not have names ready,
right?
Or they don't think this is real yet.
Yeah.
So they may have names that they don't wish to share with us yet, or they may just go by their old pronouns. So those things change as they move and as their confidence improves and they become happier people.
So you mentioned the word journey, and and for patients going through this, it must be an incredible journey to go through and a difficult journey. It starts in your office with the initial consultation. Tell us about what that involves.
Sure. So the initial consultation, you may have noticed I refer to them a lot as transgender individuals and not patients, because I just feel that they're people, and then they have a condition that we are helping them manage, and which is why I think medically the diagnosis has moved now to gender dysphoria or gender discongruence, incongruence, rather than gender identity disorder. It has a negative connotation to that, but so medically, the diagnosis would be gender dysphoria or incongruence. And just transgender basically is just like an umbrella term that sort of encompasses the gender diversity of individuals, where basically their identified gender that they relate to doesn't align with the birth assigned gender. So that's basically transgender. That's what the term means. It is an adjective, not a noun. So he's not trans or he's not transgender. He is a transgender male. So that's not their only identity. So that's again a part of the sensitivity training and recognition. So going back to your question, a typical consultation involves somebody coming in, and everybody has a story. So I first make them, and the majority of the individuals that come in to see me are anxious, believably so, as expected. I know I try to, and I think the first few layers of contact with the office where preferred names are used, gender neutral signs, definitely helps them calm down a bit. And then when I walk in, I'm usually again reiterating those facts, telling them that as a provider, I have the same values, and I will respect what you would like to be referred to as. And then after that, I usually let them speak just so they can tell me about their journey. So I usually tell them, tell me about your journey, how did it start? So just a very short, open-ended question, and then they speak. So they talk about their journey, when they became aware of their gender sort of identity or incongruence, when they became aware of that. And that story usually sort of either naturally flows, or I may have to interject with questions such as, when did you become aware? When did you share? Whom did you come out to for the first time? And it's very important for me as a provider to know what their social support network is. Do you have friends? Do you have a supportive family? Who is in your inner orbit of people that emotionally support you? So those type of questions become very important to me. So the first good part of the visit, we're just talking about their journey. And it can go in different directions, but it gives me a pretty good idea of, where they are. And I must definitely, this reminds me to state like a very important point where transgender individuals, the average age of seeking help has always been adulthood, or late adulthood, but that is changing now. And I think that has to do with the wide presence of transgender-related topics in the media, better social acceptance, and ease of healthcare.
Right.
So I think younger patients, early childhood, adolescence, all of that is now becoming increasingly the age at which individuals are seeking help.
When do most people know that they that they may want to seek some help?
So I think the seeking help probably comes later,
That's later.
but the age at which they know that their perceived gender of self doesn't align with their sexual anatomy is as early as 3 years old or 4. I mean, I've seen patients or individuals who have said, I knew when I was at the age of 3, at the age of 4, and some of them recall that moment so vividly. And I didn't have a childhood memory when I was 3, but it is amazing how they talk about it that early in life. And they were so clear. They're so clear about that perception that there is something misaligned.
And it must be so difficult. I mean, for people to not be able to seek help for so long.
Correct. Exactly.
Especially if at age 3 or 4 or whatnot, they had a sense.
So at that point, they are just becoming rebels. They don't want to conform to the society's sort of, stereotypical definitions of femininity and masculinity. They don't want. So they're rebels. They fight. And I think that pattern is changing because we have to remember parents are better educated now. They have more awareness in this. So they're quick to recognize, and they probably are seeking help sooner. But a typical adult that presents to me for care who is in his or her 30s or 40s have had a pretty rough evolution, to your point, where they've known something is off. They don't know what it is. They have constantly been rebuked or antagonized by family, society for not fitting into those cultural molds that has led to emotional mental health disorders.
Sure.
So a lot of adults that seek therapy often have more, psychological disorders than younger individuals.
It's amazing in society how we want to put everyone into different categories, right?
Yes.
And it doesn't work that way.
Yeah.
It really doesn't.
And I think now, and a lot of them, again, there was a transition where many assumed that they were gay because of how they felt about themselves. And then that transitioned. It may have been a show that they saw or a person that they heard of or a mention or something on the radio that even opened their eyes to this concept of gender dysphoria. So then it changes. So some of those go through those evolutions, but some of those, the younger patients or this generation, when they come in, they know, they're very clear about what they knew they were going through and why they're here for therapy.
So I have a couple of questions. You know how we always hear the brain doesn't fully develop until later on in life. So how do you sync these things where someone you were saying as early as 3 or 4, but yet we know the brain isn't fully developed in its judgment and its decision-making skills till later?
Yeah, I think we know that there is a biological component to gender dysphoria or incongruence, although we don't quite exactly know what it is.
Okay.
So a lot of, because the population that we're dealing with is smaller, so more studies are needed to confirm that, long-term studies. But definitely there are correlations with the neuroanatomy of gender, which is quite well developed at birth. We're talking about a lot of the frontal lobe functions and things like that take longer. Executive functioning, those take longer and they mature later in life. But I think the gender component of it
you just feel uncomfortable.
Yes. And they've also been in studies in twins that have identified themselves as transgender individuals, where the congruence is seen more in identical twins than fraternal twins, where both may not be feeling the same way. There's also some studies that have shown that maternal exposure to testosterone or whatever testosterone they had circulating in their levels before they conceived may have something to do with development of gender dysphoria in their offspring. So there are a few theories based on small studies, but a lot more needs to be done in this field so we understand what that biological component is.
Well, how old does one of your patients have to be to enter in these?
Yeah, so because I'm an adult endocrinologist and we deal with adults, 18
Okay.
and older is when we start seeing patients.
Okay.
Yes.
So if my 7-year-old child came up to me and said, I'm in the wrong body,
Yeah.
like I hear conversations where the parents are catching a lot of flack because, everyone thinks they're only 7, they're going to grow out of it or whatever.
Yeah.
But this child, like you said, has a long road ahead of him or her,
Yeah. Yes.
if
Yes.
they can't make their own decisions.
Yes.
Now, when they get to you and have that initial consultation, do you have any parameters on time? Like if they just said, "Oh, 2 weeks ago,
Yeah.
I knew."
Yeah.
Are you like, "Oh, let's
Yeah.
kind of hold off a little bit and make sure
Yeah.
this is a,
Correct. I mean, that's a great point. So I think, yes. So we have 2 broad criteria before we talk about therapy, expectations, etc. So one definitely is that this incongruence or this misalignment has to be long-term, long-standing. And the second one is that we want to make sure there are no mental health disorders that might confound this perception.
Yeah.
Okay.
So those are important criteria before a provider can actually talk about the next steps. And the gender dysphoria itself is a diagnosis within itself. There are
Right.
criteria laid out specifically for that, which kind of crystallizes to the sort of that perceived difference to be long-term, persistent enough to be affecting different walks of their life, social, school, work,
Right.
etc. So these two things are important. So the patterns are changing, but a lot of my the individuals that walk in have established with mental health professionals at the time of seeing me because they were the ones that really solidified it for them. And this often is an outlet. A lot of trans individuals don't want to come out directly as being gender dysphoric, but would rather seek attention for a mental health disorder.
Okay.
And then it's uncovered,
Right.
which is a very common pathway. So I think by the time they've come to me, they've had that expertise,
Right.
and they've had some sessions, and many times the mental health professionals in the community have been the one that have sent them my way. But I've also seen some that haven't seen a mental health professional at that time. I'm like the very first person they've talked to. So then I kind of wear that hat, although I'm not a trained mental health professional, but I mean, I've had a fair amount of experience in it that I
Right.
can talk to them and really get to the bottom of this as a more persistent, recurring, long-standing than, like you mentioned, something that just happened.
Well, I'm just thinking like for bariatric surgery, right? You have to go through so many counseling
Yes.
sessions and so much education and
Yes.
you so many classes. I
Yes.
mean, do you have those services available for someone who walks through your door and says,
Yeah.
I want to start treatments?
Yeah.
But I mean, it's life encompassing. There's so many.
Yes, you're right. Yes, you're
like
right.
what's the support like?
Yeah, so the support system, we don't have professionals in-house, like on-site, but we network with mental health professionals within the community.
Okay.
We have a list of those that we'll hand out because many are privately practicing mental health professionals, psychologists, social workers who've identified transgender health as their niche. And then there are some establishments in town as well. And then the only sort of limiting factor is, what the individual's insurance is and how that compatibility check. So that is a little hard for us to keep track of. So we just hand out the list and then they make calls.
Okay.
I highly encourage them to look on Google for reviews and things like that. And there's a lot of word of mouth within communities or social media groups that they're parts of. So in fact, those are better avenues for them to find an ideal fit for them. And I always tell them, call people, interview them over the phone. I mean, you can interview providers too. So I allow them to feel empowered a little bit.
You must have seen a progression too with insurance coverages since 2016.
Absolutely. I mean, it's amazing. Just in the last 2 years, especially when it comes to procedures.
Yes.
which I'm sure we'll talk about. But when it comes to some of the surgeries they want to get done, insurances have been welcoming. They
Very nice.
cover. So again, increasingly.
And that's more recent, right? that
Yes,
they are
yes. I
covering
would
it.
say within the past 2 years, where it's become increasingly positive.
Do most insurance companies cover this type of work?
Yeah, so two categories, right? So first therapies, and then the other one would be elective
Surgery.
procedures.
Yeah.
So for therapies,
Is
fortunately,
it always therapies first?
yes,
Okay.
it is. It is. So when it comes, so yeah, I can go down. I can talk
Yeah.
about that line of therapies
Yes.
and then procedures.
That'd be
so,
great.
So when it comes to therapy, so we'll talk about the two broad categories, right? So one is treating a transgender male who is somebody that identifies himself as male, where their birth identified gender is female.
Okay.
So they're looking to transition from female to male.
Okay.
So when that type of individual comes in, the therapies are geared towards that transition, female to male. So this is primarily accomplished by testosterone. So both men and women have testosterone and estrogen, but the dominant hormone is decided by their birth assigned gender.
Okay.
So, for instance, this individual that's female at birth but looking to transition to a male, biologically would have more estrogen relative to testosterone. So therapy basically addresses to flip that ratio. So you're giving them more testosterone in an effort to get their T levels, I'll call it T for convenience, to get their T levels in the range of what a biological male would have at birth and who has continued to live as male. And then do the reverse to estrogen. Bring it down from what a biological female has, bring it down to what men have. Men also have some estrogen floating around. So that's really what therapy does. So we accomplish this with testosterone hormone supplementation. And then the appropriate term for that is cross-sex hormone therapy. That's what I refer to, and that's what all the organizations refer to as. Not so much hormone replacement, because you're not replacing, but you're transitioning. So that's a more appropriate term, is cross-sex hormone therapy.
So you're giving testosterone, but how do you lower the estrogen levels?
It's inbuilt. It happens automatically. So when you give testosterone, it modulates the brain signaling such that their ovaries don't make estrogen.
So it's kind of like a seesaw in the
body. So the testosterone does that naturally. So the testosterone that you administer accomplishes two things. One, it brings about the changes, the masculinizing changes that testosterone is expected to bring about. And it automatically, as a second step, it also drastically cuts down the estrogen production by the individual.
How is the testosterone given?
So different formulations, but the injectables are commonly administered because they've
only in office?
No, we teach them how to do it.
Nice.
And we subcutaneously under the skin.
Okay.
And it is very hard. It is hard for the community to just come out of the gates and say, "Oh, injectable therapy." There's always some phobia around it. So we hold their hands. We tell them eventually we like you to be independent with doing weekly injections, usually weekly. So we'd like you to be independent with that, but we'll hold your hand. We'll have you. The first time we'll do it for you. Another visit, we'll watch you do it. If you want another visit of that, we'll do that. So, and most of them are flying by the third or fourth visit. They're good to go.
So how long do they have to, when do you start seeing results and feeling a little different?
Yeah, so there is like a timeline to that. So some are early changes and some are later changes.
Okay.
And I basically tell them, you're going to go through puberty all over again. This is going to be the most exciting time of your life. And
Right.
And most of the times at their first visit, I'm actually prescribing them therapy at the end of our interview. Majority of times, some exceptions, but most of the times, and they're in disbelief because
they have to
didn't
be
expect.
so happy when they leave your office.
Oh
It's
yes,
like
I
you're making
have.
progress.
There's a lot of tears of joy. There's a
course.
lot of hugs going around, and it's a very emotional end of visit.
It's like they see the end of the struggle.
Oh, absolutely. Very gratifying, in a different way. So the changes are, in early changes for somebody that's transitioning from female to male, we can go from top to bottom. So what happens is there's facial sort of skin. The skin changes. So their skin becomes oilier. And that's because of testosterone-induced increased activity of the glands, sebaceous glands, sweat glands. And that can make them prone to acne sometimes. So that's something we talk about. But these are like happy acne of second puberty.
Happy pimples.
Yeah, happy pimples, right. And then the voice, that changes very early on. Their voice, they get deeper, more low-pitched, low-tone, low resonant. And that happens very early on. And again, when I talk about treatment expectations, this is one of the first things I talk about, because that particular change that happens to the vocal cords is irreversible. So I think thanks to social media, a lot of people come in knowing expectations of treatment. So it makes my job easy, that because I'm just doing a review rather than telling them everything.
So when you say very early on, we're talking like the first couple of weeks?
Weeks.
Okay.
Yep. And I always tell them, test it out on your friends. Call them and they won't know. They'll think it's a prank call.
Really?
They get such a kick out of that. Like, no, you're not that person. That's somebody else. So that happens. So voice changes. And then hair. So hair growth becomes it comes on pretty early on the face. They start getting facial hair, little peach fuzz first, and then it intensifies. And those are all moments of victory for the individual, like huge moments. And then going further down, not a whole lot of breast changes occur in somebody changing from female to male just from testosterone therapy. So, which is why little segue to procedure. This is one of the most requested procedures in transgender men, which is chest reconstruction. So they have breast reduction followed by reconstruction. That's done so that the chest kind of fits the male contour. And I think we have some great plastic surgeons. Again, it's all about practice, volume.
In the area?
And they've been doing it for so long. Some in Boston too. But I have a list. It depends on, so I usually tell them from nearest to 40 miles away. And I'm constantly updating it, because when people come to me, where did you get it? How was the experience? So I'm constantly updating my lists.
You know what's great too is they can kind of map out their journey. They'll be like, here, I'm going to be probably here, and then I'm going to be here. And
honestly, this is one of the first things I told the first 3 patients that I had. I said, I'm starting this, and you are going to be my teacher. Like, I want to learn from you. Like, I know the guidelines. I know, and I have had some exposure during training. But again, it was a long gap of not caring for them and then starting back. And I continue to tell them, you tell me how it is. How did it help you? And I'm constantly learning from them, so which is great.
What's the general feeling like health-wise? Do they feel crummy, or do they feel like pretty good?
They do. So what happens is initially the physical changes happen. Breast we talked about, not a whole lot. And going down further, there's a little bit of fat redistribution. So with testosterone, testosterone promotes fat accumulation in the belly, sort of like the male gut belly. So it moves from subcutaneous fat, so their hips and their thighs become less curvier, and all of that fat moves to the belly. And then going down further, one of like their top priorities is cessation of menstrual cycles. And that's like a huge, victorious moment for them. So that happens. They do undergo some changes in their genitalia as well, some clitoris enlargement, which is testosterone-induced. So these would summarize the physical changes. And then the emotional changes. So I think the emotional changes parallel the physical changes. So you can see as they see that, and the sort of the incongruence, the misalignment vanishes, where they feel more aligned with that. Their identity of self aligns with these new physical features. So with that, a lot of their dysphoria, a lot of what may have been identified as run-of-the-mill anxiety and depression kind of dissipates. So a lot of them experience significant improvements in their previously diagnosed psychological issues, which have basically stemmed from dysphoria. So we see people coming off of some of those medications,
hitting the root cause.
There must be a lot of anxiety and depression, I'm guessing.
Absolutely.
Before the journey starts.
Absolutely. And I see that more, like I said, in adults who choose to do it later in adulthood, rather than people that come on sooner.
Can their families come with them and be involved in this process?
Yes, and that all depends on the support from their family. So I've seen some come in with parents that are their advocates, champions, they're rooting for them, all the way to, they come by themselves, or they have a best friend, or they have a transgender friend, or they have a roommate. So it's such a wide spectrum. I've seen everything. But then I always involve them in the discussion. Sometimes it's the parent that's leading the discussion. The individual doesn't talk much, but I make it a point. And sometimes I'll have the parent, leave the room briefly so they can open the floor to them for questions. So we do it different. So it's so individualized. I mean, I thought diabetes was individualized, but this one is like, no two people are remotely similar. It's so huge because their circumstances is what makes every person so different.
Is there anyone that has contraindications to this and they just can't go on testosterone? And then there's an alternative?
Yeah, so very few and far in between. And that goes to... and I would say even if there are, they would be relative contraindications, not like solid, no way. And these would be around some of the potential adverse effects of testosterone treatment. One of them is an increase in the red blood cell count. The other one is increased risk of blood clot formation. And then increase in blood pressures. So at baseline, if they have any of these, hypertension that's uncontrolled or history of blood clots, and things like that, or high red blood cell count, we might talk about addressing that first before. But I don't believe there's anybody that I have who has come in asking for therapy that we haven't been able to take the next step.
So the vast majority has done
Yes. And then some are the transgender sort of term also encompasses individuals who identify themselves as non-binary, where their self-identified gender is neither male nor female. It's probably a combination of both or it's fluid. So for those, most of the first visit and maybe even subsequent visits is about what their goals are. What do they like their gender expression to be? Or would they like to try a certain path first, or would they like to try another? So that is very different. So in such cases, they may not get started on therapy right away unless we are both on the same page. Like, what are we looking for, and how can I help you get there?
So let me ask you, we're going to talk a little about surgical therapy a bit later, but let me ask you, we talked about the journey to become a transgender male. How about the opposite? Transgender female. That's going to be a whole different journey, obviously.
Completely different. So the underlying principle again is biological male at birth doesn't identify self as female. So we are flipping the ratios. So we are again bringing down their testosterone levels down to what's normally seen in females, and then bringing their estrogen levels up to what's commonly seen in a biological woman. And that is accomplished by estrogen therapy. So they mirror image each other conveniently. The endocrine system is defined such that if you raise one, the other one will automatically get suppressed. So that's convenient. So this is accomplished through estrogen therapy. With estrogen, you have the option of just going the oral route. With testosterone, it exists too. It exists. There are other routes too, like gels and pills and patches and everything. But as far as an insurance coverage perspective, the injection route seems to be the path of least resistance. We may change therapies later down, but they're always asking, and even for me, they've waited all their lives. You want to choose the path of least resistance, and then iron it out later. So for women, that path of least resistance for transgender females is pills. So they start on pills, but for them, they need an extra layer of treatment also, because the pills raise their estrogen levels beautifully, bring down the testosterone levels, but not to zero. And testosterone, being such a potent hormone, can still exert its influences on body tissues. So that is why we also need an androgen blocker or a testosterone blocker, which is also a pill. So these travel hand in hand. So there's an estrogen pill and then a testosterone blocker. So together they accomplish all those changes, which again, if I were to review from top to bottom, it's almost the opposite. So their skin gets less oilier, it gets softer. If acne was a problem, bye-bye to acne. Then voice does not change. So in cross-sex hormone therapy, because these individuals were biologically male at birth, they were exposed to testosterone, the vocal cords have undergone that transition, which we talked about is an irreversible change. So estrogen therapy won't reverse that change. So for those individuals, who are seeking for focused therapy. We refer them to speech therapy. Or I was only recently told by somebody that came in recently that there's a lot of tutorials now on YouTube and things like that that they can just watch.
You can learn about anything on YouTube these days.
Yeah, right?
It's amazing,
I know.
isn't it?
So the focus is on improving and increasing the pitch and resonance of your voice.
Okay.
There are surgeries available too. There are very specialized centers that do surgery to vocal cords to make the output more high-pitched. So voice does not change. But again, breast changes are very obvious and to the individual.
As an early change?
Early change, as an early change. So puffiness, sensitivity. And I always tell them, again, it's about setting expectations. They are very evident, apparent to the individual.
Do they lose chest hair?
Yes, they do. Okay. They do. They lose hair everywhere. But that's a very late change to happen.
Okay. Will a transgender female develop enough breast tissue to actually have breasts, or do they require surgery?
Yeah, so it's usually just enough for them to appreciate it as a major landmark change, but typically not visible, obvious enough for somebody that's observing. So that's, again, the expectation we think. So, and for that reason, breast augmentation would be probably the second most, sort of sought after procedure for transgender females. The first one being facial feminizing surgery. And I'm just talking from my experience in my population. The general world data might be different, but a lot of them seek facial feminizing surgery to sort of.
So we're talking like forehead, Adam's apple.
Nose, Adam's apple. Yeah. Okay. And again, even those are increasingly now being covered by insurance, but that's like a welcoming change. And then again, when you go down to the body fat distribution, the reverse happens, so they have more intra-abdominal fat, gut fat, and that kind of switches out, curvier hips, thighs, again, all welcome changes. Their genitalia takes, because you're depriving them of testosterone, the scrotum testicles can shrink. They may not have as frequent erections as they used to, which, some are comfortable with that fact, because for them, again, every person has a certain body attribute that gives them the most amount of dysphoria. So for a transgender female, if it's erections, that sort of coming down in frequency is huge for them in how they feel and how they perceive self.
Dr. Lakshman, I'm confused too on one thing. When you say transgender female, do they have to cross a certain barrier to be considered a transgender female? Is that someone who's gone ahead and gotten, the surgery?
Yeah.
So
I think for us to say that the transition is complete, complete, it would, of course, end with surgical option, where there's two things: removal of your reproductive organs, which would be testes in case of transgender female, or ovaries and uterus in terms of a thing. So that's removal of the reproductive organs, and also reconstruction surgery.
And is that what most people like that? It's what's considered the end of their journey, or do people stop? Are you seeing people happy before that?
Yeah, your latter comment. So we call it bottom surgery or gender reassignment surgery. That would be going the whole 9 yards. But I would say only a smaller group of people actually go the whole 9 yards. So again, it's really up to them.
Right.
Like, is your transition complete?
When you feel comfortable.
It's in my books. I have transitioned.
Nice. But the term transgender, male or female, it doesn't have to include that. Correct. It can be. It's whatever the person considers.
Correct.
It's an individual definition, I guess.
Yeah. It's your gender identity in alignment with how your body feels, looks. Right. So as long as that's aligned, there.
So someone may have been born as a male physically, but consider themselves a transgender female without even having any therapy.
Yes, they can just consider themselves that. Yeah,
and that's an important distinction to throw out there.
There are no goals. Yeah, so that's a good point. There are no goals or milestones to achieve in order to, sort of be qualified for that term. Yeah, when you decide, and then the formal diagnosis is made, either by a mental health professional or a provider like myself, we validate that.
Dr. Lakshman, what are the biggest challenges that the transgender individuals face in your clinic? Like what?
I would say the number one would be social support, social and emotional support. I think that would be number one. And number two, probably stemming from that, would be financial circumstance. And again, I think just the circumstances, lack of support, emotional, a lot of them don't feel confident enough to go seeking jobs or to work or further their education. Again, fearing discrimination from,
Were there any challenges that you faced opening up the clinic and running the clinic?
I don't believe I did.
You seem so enthusiastic about it. Like
and
I said,
I
you
had the
pushed for it
support
so early
of
on.
our
Yeah.
primary care, our group, and such a lovely and supportive staff.
Great.
We're all equally sensitive. They share my passion. So zero for that. Yeah.
You brought up about, the transgender community, how there's so many societal struggles out there, and we know that there's a lot of discrimination and violence against transgender individuals.
Yes.
Do you think that will ever stop? Do you think we'll get to the point as a society where we have a deeper understanding and acceptance?
Yeah, I wish, and I think going by the current trends, I believe that, we will get closer to that. We get there, hopefully, but I think we are getting closer.
Just for the sake we're having a conversation.
Yes.
I mean, I think a lot of things start with a conversation.
Well, I think every generation, it seems like they're more, knowledgeable. I mean, my generation wasn't knowledgeable. And, I've learned as time gone on.
Yes.
And it's important that we do that as we grow.
Yes, and I think you will see that the younger generation will start getting introduced to these concepts very early on.
So too.
Because my 8-year-old came up to me just a couple of months back. One summer camp started, and he said, "Daddy, what's transgender? We have a transgender child in our thing." Right. And I said, "You've come to the right person. Let's sit down and talk."
He couldn't have asked anyone better than you.
So we did a little cartoon and explained everything to him.
Great.
God,
my daughter was playing in the background. She came on, and everybody, it became like a nice tutorial. So I see that they'll start seeing, as we are seeing the age of seeking medical help is getting earlier, younger.
Right.
The awareness hopefully will spread among peers, so that gender humility starts getting ingrained into the society earlier on in school.
Yes.
So they've been around such individuals, so that way going to work or to college or to any place else, it's not a novel thing. It's something they've experienced before.
Now, I know you're not a surgeon, and we don't do surgery here
Yeah.
in Fall River for transgender individuals,
Yes.
but maybe just briefly tell us a little bit about what the
Surgery
experience of
entails.
surgery entails
Sure.
for both transgender men and transgender women.
So for transgender men, again, depending on what their goals are, if their dysphoria was mostly associated with having, for example, ovaries, having a uterus, even though therapy has made them sort of cease their menstrual cycles, just the dysphoria may be associated with having those organs within them. Nobody can see it, but they know
it's there.
They feel it. So if it's for just such therapy, it's relatively more straightforward. I have local surgeons, OBs, that are welcoming to transgender individuals that are able to do that.
Nice.
So that becomes manageable locally. If they want to go to the next step, which is gender reassignment surgery, that is more complicated because we are basically, for a transgender male, we are talking about altering. It's called vaginoplasty, where the tissues are sort of altered. Very complicated surgery, as you can imagine.
I can only imagine.
You're creating a scrotal pouch. You're creating, prostheses that kind of serve as testicles. You're sort of shaping out the skin to form penis and add tissue and everything. So complicated. So again, fortunately, we have programs. So Boston Medical Center is like our nearest big center that has made some remarkable strides in gender reassignment surgery just within the recent years.
That's great.
Rhode Island Hospital as well, but for a lot of my patients that have Mass Health, Boston Medical Center is the default go-to place. So again, just like bariatric surgery, it's a long process. They evaluate them. So for gender reassignment surgery, they need to have been on cross-sex hormone therapy at least for a year and lived their desired gender at least for a year.
Of course.
That stipulation exists. That doesn't exist for a lot of the other procedures,
Right.
such as top surgery, facial surgery. No. So that is a more extensive surgery, involves more detailed discussion, and in this case, really setting expectations of how their lives will change, how their sexual lives will change. At that point, I know these centers have patient advocates whom they can talk to, who have gone through it themselves. They can share experiences and things like that, because the last thing they want to do is regret from surgery, because it is irreversible.
Right.
These are so extensive. It is.
Do they continue to see you through all this? Like,
Yes.
when do they start? So they see you if they go.
I'm a part of their entire journey. It's just
Okay.
that the frequency of their visits will kind of reduce as they, but I at least see them once a year.
Okay.
When we start out, they're seeing me often,
Nice.
every few weeks, months, and then again, expectations, they change. So that's what we ask.
Yes.
Like, are you happy where you are? What else are you thinking of? What else can we achieve for you? So that changes. And hence, the frequency of follow-ups can be titrated.
That's great.
And when it comes to surgery for a see, I mean, even I'm slowing down because I have to think
Right.
the pathway, so I say the appropriate things, and which is how I am with my individuals too. So I'm sensitive, I am deliberate, and I'm correct, precise. So for these individuals, basically, we're reversing their anatomy. So for a transgender female now, they again, if their dysphoria lies mainly about their testicles, just that, a lot of them will just opt to just have, we call it orchiectomy, they'll just have their testicles removed, similar to the organs removed on the other scenario. But then again, if they want to go the whole 9 yards, it's more complex. So again, surgery we can accomplish locally. I have my urology friends, colleagues who are very supportive. And then if you're going to the next step, because again, it's a higher center because of the scope of work involved, where they're reshaping the vaginal tissues, skin, to sort of create the desired organs. Right. Yeah. So that is more extensive. So like I mentioned again, I would say a smaller group of people actually go up to gender reassignment surgery. And again, it's everybody's will and wish. And again, that doesn't mean that the ones that have not opted for those won't in the future. It can change.
Nice.
Right. So basically, they can start with you and go through the whole journey with you, and anything that they require that's out of the area, you have access to and help them with, which is really, really remarkable.
Exactly.
That's great. And they can stay in their own community where their supports are.
Yes.
Which is so important.
Is there any reason for you to know, if you accept a new patient, that they're a transgender female, a transgender male? Would you work them up differently?
I think it would be important for me to know, so I'd be sensitive and use the right terminology in that,
right,
I
but
guess.
like
You're
biologically?
talking about like cancer screening and...
Yeah, how does that all work?
Well, that's a complicated issue. We could probably do a
is.
who other podcast
I know,
on
right?
that, quite
but
honestly.
Just the summary of that would be, you would screen them like you would screen the term for, in this sort of situation, I would refer to a person born male who stayed male as a cisgender male.
Right.
So you would treat or screen for cancer in a transgender male just like you would in a cisgender male. So, but again, you have to be aware of some of their tissues that are still present at birth. For instance, breast screening. So for a transgender male who has had breast reduction, removal, reconstruction, they don't have any breast tissue. So breast cancer screening doesn't apply to them. But if they have their breast tissue, then you would do mammograms like you would for a cisgender female. The ages
Makes
are the
sense.
same. But if there's an extensive history of breast cancer, things like that, modifiable risk factors, you would modify your screening. So that doesn't change really.
Okay.
It's just same. Likewise, for transgender males that haven't had any gender reassignment, they still need their pap smears. They need appropriate screening.
You really need to know what they've had done and kind of how the anatomy has been changed to know how to screen.
Yeah. And then same for transgender females, they have their prostates, which stays. I mean, that often is not a significant thing contributing to gender dysphoria. So we don't typically have requests for prostate removal. But the incidence of prostate cancer in transgender females is very low because you've deprived them of testosterone.
Right.
So, you know, it's such a key factor.
Right.
But you would just do age-appropriate prostate cancer screening in transgender females like you would do in a cisgender, in a cisgender male.
Thank you.
Same.
Right. This is great. It's been a great conversation.
Yeah, of course.
So, two more things. One, could you leave us with any success story you've had? Obviously, without identifying
Yes, of
anyone.
course.
Is there something that really sticks in your mind that you can tell us about that would be interesting?
I think I would say the one that comes to my mind right off the bat, as soon as you said that, is a patient of mine who came to me last year. Her appointment was on her 18th birthday.
Mm-hmm.
You know, and just that by itself moved me so much, you know, that trans female, her preferred pronoun was she, her, that she had waited because in between transition between pediatrics and things like that, she had lost providers, she was without providers, she had heard about us. And her appointment was, the earliest appointment she could get was at 9 a.m. on her 18th birthday. So, you know, so she came in with her grandma. I mean, she...
Oh, wow.
Has a very supportive grandma.
That's great.
It's amazing, you know. All you need is one person, a pillar of support. So when she came in, she didn't make eye contact with me at all throughout the visit, the first few visits, I should say, because of just sort of the mental trauma she had undergone, where her only family member who was supportive was her grandma. She had lost everybody else through her transition. So as far as schools and things, education, everything had suffered as a result of it, not working and things like that. But then, you know, we went through our process. We slowly started therapy. And I could see with every subsequent visit, just this sort of the little glitter in the eyes, the sort of the sitting upright as opposed to, you know, just the body posture, eye contact, everything just built so nicely, you know, through the visits to a point where she didn't bring her grandma to some of the visits. And I said, wow, like that is, you know, I high-fived her. I said, yeah, this is amazing. And then she would inform me of, you know, wins through the procedure where, through the thing, because one, she had enrolled for an online course through the pandemic. Now she has a job.
Oh my gosh.
And it's just been an amazing... And I just remember her so clearly because of sort of the circumstance that I saw her. She had just, you know, and I have many stories, but this one is the one that would come to my mind. And now she's an independent woman. She, you know, she has a partner. She lives independently. She has a job. She's furthering her education.
She finally feels good.
Yeah, those success stories really stick with you.
Very gratifying, you know? Yeah.
It is gratifying.
Her grandma is still in touch. She'll send me emails every now and then.
That's great.
So
that's wonderful.
Yeah.
So as we close, is there any one message you would like to leave our audience today?
Yeah, definitely. I think the transgender community is very dear to me, I think. And I think that comes from the gratitude that they have in their hearts towards our office, our team, you know, who are very welcoming to them. And as a provider, I mean, that really touches, you know, a chord with you, you know, because they're in that state throughout your relationship, because it's like a gift of a lifetime that I've hopefully given them as a provider and as a team. I always say team because it takes so many of us in the office to do this. They're kind, they're thankful. So, you know, I definitely want to say that patterns are emerging. We talked about that, or changing rather, where individuals are seeking care earlier. So I want them to know that, you know, we are here. The medical care is available. So if an individual needs help and support, to reach out to our office, even if we are the first point of contact or the first human being that they're sharing their stories with, you know, we are here for you. So
yeah, that's a great message. Well, I want to thank you for the great work that you're doing. I mean, it's just so important. And if there are persons out there who do want to get in contact with Dr. Lakshman, you can contact the Transgender Clinic at Primacare Medical Center. at 508-235-0481. 508-235-0481. And we'll have that posted later on also. So I want to thank you, of course, for this wonderful discussion. It was really enlightening, and you're doing wonderful work. Thank you.
Thank you very much. Thanks for having me. It's a pleasure.
Oh, it's our pleasure. And I want to thank, of course, Bay Coast Bank for supporting our podcast. And Bay Coast Bank is right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And this is the 27th Degree with Chris and Nancy from 27 Degrees Consulting. Thanks so much for tuning in, and we'll see you again in another week or so. Take care, everyone.
Bye.